The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always.
Welcome back to the Virtual Curbside. This is your host, Paul Wirkus, this month talking to Dr. Anna Ermarth from the Division of Pediatric Gastroenterology at the University of Utah on Primary Children's. Welcome back, Anna.
Thanks. This is fun.
The good news is that by the end of this month, we will know everything that is known and that can be known about celiac disease. Do you subscribe to that?
I do. And I really like, you've had a previous book club discussion with Dr. Giardino about how general pediatricians can sort of edge their way into subspecialties, and we really kind of complement each other. And I think this is exactly one of those diseases that I want to promote a general pediatrician feeling confident about taking care of these patients just as much as I feel confident about diagnosing them.
Excellent. In the intervening week, have you developed any conflicts or disclosures?
I didn't try hard enough, no.
No, I think you need one. So to those of you who have potential conflicts for Dr. Ermarth, please send your conflicts to conflicts@vcurb.com and we will pass those along. We talked at some length last week about what celiac disease is, and that so much of this hinges on the fact that it is an IgA-mediated disease, which makes it more mysterious, right, than IgE in some ways.
Maybe, yeah, more mysterious, less obvious, take your pick.
Yeah. So now we want to plumb the depths of celiac disease testing and establishing a diagnosis of celiac disease. So first of all, who needs to be tested? Which GI symptoms? And I think you suggested last week that question B is going to be the more complicated one here. But which GI symptoms suggest the need for testing?
Well, before symptoms, let's review those diagnoses, right? So we touched on the fact that a type 1 diabetic is going to get screening after they're diagnosed. I also tell parents this a lot. Type 1 diabetes gives you the genetic setup to have celiac disease, but the reverse is not always true. A patient with celiac disease will not be as high of a risk for developing type 1 diabetes. So that's kind of a good thing to remind families who are nervous about that. We don't want them taking blood glucoses every 2 days on their patients when they get grumpy, or on their kids, not patients, excuse me. And then trisomy 21 patients, they're going to be screened about yearly to every other year. Usually once you've had about 4 or 5 years of a negative serology, you can slow down on that screening. Maybe the guidelines don't reflect this, but you can sort of start looking a little bit more at symptoms and then screen about every 2 years, save the patients a blood poke. And then thyroid disorders, once you've diagnosed with a thyroid disorder, that's a high association of an autoimmune disease with celiac disease. So there is not a guideline to say to test yearly, but be a little bit more curious for that. And then Turner syndrome, and actually any genetic syndrome, I just say have a lower threshold because they can be a little trickier with their presentation. So those are the diagnoses. And then, of course, having a first-degree sibling, that would be someone else to be a little higher alert to test if they had symptoms. And then everyone else, so the symptoms I say that, yes, you need testing for would be the classic, right? The diarrhea, the bloating, the kid who just stops eating and looks a little bit more distended, and is like not into it. So those are the ones I'm always going to say, yeah, it's worth testing when you have a malabsorptive process that you think is going on. Everything else is a little sneakier. So maybe it is the kid that stops eating a little bit and then slows on his weight, but really is kind of a good kid to, run around at recess. Still have a low threshold to test if you're worried about it. And then like we mentioned in the first one, the psoriatic looking rash. It's not psoriasis. It would be the herpetiformis, but something that isn't going away after classic eczema treatments, I think should have testing as well.
Going back to the diarrhea, how long would you tolerate diarrhea before you say this needs testing?
Well, in case the audience didn't know, there are definitions of diarrhea, and I love applying these as a gastroenterologist. So diarrhea, of course, is liquid stool more than 3 times a day and lasting at least more than 2 days to make it an acute diarrhea problem, but then certainly over, I think, a 2-week period makes it a little less acute. Now, there is 20 different causes of diarrhea that last for 2 weeks, or more than 2 weeks in our differential as gastroenterologists. However, usually an acute infection or something else in a diet that changes you to diarrhea is going to resolve between about a 2 to 4 week period. And again, if you're having patients that are kids that are going diarrhea in the middle of the night, that's never normal and should make earlier testing happen.
How does testing change with age? At what age would you start testing for celiac disease?
So unless they're in that category of more severe presentation with diarrhea and really, even though I hate the word failure to thrive, a malnutrition presentation, those deserve to be tested, especially if they're under 3, because the under 3 population always seems to present a little more severe. The rest of childhood and adolescence, that's a little trickier because these symptoms kind of wax and wane differently than a young child.
And part of the reason for the age, as you suggested last week, is that it takes a period of exposure to develop. But
Right.
there again, the more severe cases will present earlier. Is there an age at which you can't trust serologic testing?
Well, under 2, again, same concept we've been reviewing. I think it's the fact that their gluten exposure hasn't had a long time, and they can come back seronegative, but that's seronegative, meaning blood work is negative. That's a pretty rare presentation. But again, that can happen. So that usually deserves a more robust workup by a gastroenterologist.
Let's talk about testing then. Let's start with serologic testing because that is really quite a boon to the whole process, right?
Yep, you cannot diagnose celiac disease unless you have positive blood work and in some cases positive biopsy, but the blood work has to come into play.
Tell me about the anti-TGIGA antibodies.
The key word here is IgA, and that is the first step. So we all have IgA, IgG, IgD, IgE. We have lots of different immunoglobulin classes, but IgA is what makes this a disease because it lives in your mucosa. If you don't have enough IgA, we can't really apply the blood work for the rest of the celiac workup. So the first step is making sure you have that serum IgA level. You can order them separately. You can order a serum IgA and then go down to the tissue transglutaminase antibody antigen test, and that you can order separately. However, our labs have some sympathy on us and have made these reflex panels or algorithm panels. So they usually will automatically screen for that IgA level when you order one of these panels. And then if your child has enough IgA in their system, it'll automatically go down to the cascade of the tissue transglutaminase or anti-tissue transglutaminase IgA. And that transglutaminase is the enzyme that you need to break down gluten. And I really call this test the TTG IgA is how I'll call it the rest of our episodes. But I think it's the greatest test of all time. I mean, it is so specific. It looks for one thing in your blood that as a diagnostic process, it's really satisfying when you use this blood work.
So let me ask a simple-minded question because I was born to ask simple-minded questions. So if somebody is IgA deficient, are we talking about a temporary condition? Because if celiac disease is an IgA-mediated disease, can you have it with IgA deficiency?
Yeah, and this is a tricky part, but yes, there is about a 1 to 3 similar prevalence in our whole world of IgA deficient persons. And again, as I say, you can pick your friends, you can pick your nose, but you can't pick your parents. And so it's a genetic setup. And, if you have selective IgA deficiency, you will walk around and not really notice a difference in much things in life. There's some thought that maybe you get respiratory infections or things that affect your mucosa a little bit more often. I'm not sure that that's well founded. But yes, you can have IgA deficiency and still have celiac disease, but those are the patients, again, that we sort of have to skip the blood work for and go straight to the biopsies.
Okay. So are there other blood tests I should be thinking about besides tissue transglutaminase?
There are, none of them are as good, but one of the nice advantages of this blood work, and everyone, I think I'm speaking to the pediatricians who know this, it's cheap and they're widely available. So,
Huge,
in
right?
terms of
That's huge.
Yeah.
There are lots of really good tests that cost a lot of money,
Right.
are very difficult to perform, or are not available. And this is none of those.
Exactly. And that's, again, why we partner with general pediatricians on this. I don't need to order that as a gastroenterologist, but they can be hard and tricky to interpret. So I'm still going to walk everyone through that a little bit. but it's an easy test, it's available, and you can put it with a million other things in your blood work if you want to get those, like your CBC or your CMP, that sort of thing. So a patient that has enough IgA should go on to have the TTG IgA. All of the testing percentages we talk about with this test are good. The sensitivity is amazing, right? It's going to catch it if it's there. And not only that, but it's a real ordinal scale test, meaning a 0 is a low risk and 100 or 200 is an absolute high risk. And so it's a nice test to interpret that doesn't seem to fluctuate 2 months once it's in those higher realms. So if 1 week you have 5 times an upper limit of normal of this test, the next week you're probably going to be maybe a standard deviation of 1 to 2 within that upper limit of normal, but it's still going to stay high, especially if it's truly identifying the antibodies to gluten. The higher this test goes, the better the positive predictive value goes, which is really easily interpreted. So same idea, the higher it goes, the more likely you're going to have enteropathy or damage to the intestines that will come positive on a biopsy.
So there are other blood tests available, but there's not any reason why I should concern myself with those, right?
Yeah, and the panels that I mentioned from the labs, they still run those. And mostly because, again, we do have them. So we do have IgG mediated tests to look for risk of celiac disease. However, every time I see a new article coming about the value of an IgG, it really just says these are not useful for diagnosis. The IgA tests are actually used for diagnosis. And I think that's a big difference. So when you're looking at this and trying to interpret, okay, what do I have to tell the family? The IgG values, and that includes a TTG and deaminated gliadin, which is D as in dog, DGP, those tests are really going to be less usable with the IgG.
So in terms of my approaching a screen, I don't have to master a lot of stuff.
If you stuck with just the TTG IgA, you're in good shape. Now, there is other confirmatory tests that we use, and the next one that's the next best is called an endomesial antibody, and that we call the EMA. And those are usually not included on the panels because they're a little more expensive, a little more sophisticated of a lab. So I think it's actually smart of labs not to offer that right away from a cost perspective. But that one has a performance value, a specificity, and a PPV value just as high as the TTG. So I often use, when I have a patient with a high TTG IgA, I use the EMA test as more confirmatory to say what is a child's risk that these biopsies are going to be positive for celiac disease. So that one is a great one to use in conjunction, especially if you're in a mid-range of the TTG test, maybe between 3 times the upper limit of normal to 5 or 6 times. And the families haven't committed to going to a GI doctor yet or wanting a scope, you can certainly use your endomesial antibody test as the next best test.
Let me just ask one more question before we jump right ahead to biopsy and whatnot. Is there any advantage to doing HLA typing under the circumstances?
The advantages are it's also becoming more cheap and more available. And that's exactly what a 23andMe test is, right? So they're going to look for those genetic HLA factors. And to have celiac, you have to have a DQ2 or DQ8 HLA haplotype. And so we can certainly look for that. That is about 40% of our population and higher even in Europe. So the Italians have looked for that, and the Italians do general screening of their population. And about regionally, it's between 40 to even 50% of them have that HLA type. So for them, they feel like, well, that's enough of them. It'll make it worth it to screen there first and then add on the other antibody test if needed. However, I think that's a little tricky too, because just because you have the genetics or something doesn't mean you're going to have celiac disease. Yes, it's a higher risk if you have a strong autoimmune disorder history in your family. But, my mother has giant cell arteritis, and I don't feel the need to go out and see what our haplotypes are because, in some ways our environment is going to shape more maybe of our disease risk in that way. And so I caution people when they want to do these genetic tests, and you can do them. I mean, I actually think 23andMe is no longer with us or going in a different route, but it doesn't mean you're definitely going to have celiac disease.
And you always have to weigh trying to navigate. So I've got a risk factor from I have a disease.
Correct. Exactly. And that's, again, the controversial piece of this. Some people believe if they have a genetic setup, they can maybe change their lifestyle and reduce that risk. But I'm not sure taking a complete gluten out of your diet is going to ultimately, have a better quality of life for someone.
Okay, let's go to the next step. That is the universal next step, but you may argue that it may not be the universal next step if I'm reading you correctly, and that's biopsy. Small intestine biopsy is the gold standard for establishing the existence of celiac disease. Is that true, and will that always be true?
Again, I love the controversy in our disease here, but biopsies are the gold standard. They are the gold standard because, like I kind of said, it's the in line, right? I mean, it's an easy piece of tissue to get relatively, maybe not compared to a skin biopsy. Skin biopsy would probably be the only thing that's more easy to get. Saliva and blood, of course, probably trump this. However, it doesn't always mean that there's no human error in that process. And so when we have patients that come in and say, this biopsy test is going to be the end all be all, I have to remind parents, well, there's risk with it. We still have to take something that causes you to bleed, and that bleeding could go uncontrolled. There's the risk of anesthesia with it. So, young children under anesthesia is something no one really likes. I will say our scopes are about 8 minutes long, so the exposure to anesthesia is low. And then there could be bruising when we go in there that actually can cause you to have gastric outlet obstruction, and that would have, pretty dire consequences as well. So there's a little bit of risk just doing the procedure. But then with that, there's still a lot of human error involved in the process of a biopsy. So then that little tissue piece has to travel to the lab. And by traveling, it's a person walking it over. And that person walking it over has to put it on the desk correctly. And then the lab tech has to take that tissue and put it on a slide correctly. And then that slide has to get set up and then have another set of human eyes, our pathologists, which we love, and they've really done a great job of standardizing it. But there still are several tests that could kind of make the interpretation of these slides a little bit less accurate. So again, I would say that our blood work actually in this case could lead to a diagnosis, even less risk of human error involved.
I think I've heard you refer to biopsy as maybe not being the gold standard anymore, but maybe the bronze standard.
Yeah, exactly. I mean, if we're ranking things here, there's less human error, which, means that we all get a chance to make a gold or a silver in our lives.
Well, besides that, the Treasury Department has silver standards, so we'll go with bronze. That's very reasonable. So, what do you recommend then? Let's skip ahead a little bit and then work back from that. Is biopsy the gold standard worldwide?
I think that is probably a misnomer now, and maybe it's the last time we use the word gold standard in this case, but no. So the Europeans, because of their really in-depth studies on how good this serology or blood work for TTG test is, have gone away from always recommending a biopsy. So the Europeans use that test. Like I mentioned, the higher it goes, the higher chance you have disease. And now they've taken those upper limit of normals and made it a diagnostic level. So if you have 10 times the upper limit of normal of your serology test, and again, you got to be careful when you read that test because one lab may run a test that's a 0 to 20 is normal or negative. The other lab might run a test that's 0 to 5 is normal or negative. So you can't take the absolute number. You got to convert that into just standardize upper limit of normal for those. But if you get above 10, you have the opportunity as a patient or consumer to be very confident that your biopsies are going to be abnormal. So why undergo the risk if we already know that? And the numbers coming back don't lie. It's a 99 to 100%. And of course, nothing in science or the world really is going to be 100%. But I feel pretty good about taking a 99% chance that I'm going to have an abnormal tissue biopsy. So yeah, we can forego scopes if there's that high positivity. And so the Europeans have done this. And I think another interesting thing that we haven't talked about is that these have actually come under pediatric standards before adults. This is a very rare case where our pediatric investigations have actually changed guidelines before adult disease changed their guidelines. And so that makes me really proud of this as a pediatric gastroenterologist. And so now the American College of Gastroenterology and the AGA, so both of the adult-based gastroenterology groups, have changed their guidelines to follow what the Europeans are doing, which is when you have that really highly positive test, you can forego a biopsy.
We're talking about the European standards here, not just because we think the European physicians may be snappier dressers, but because the likelihood of celiac disease is quite high in many European centers and leads to a different way of approaching this.
Yeah, they have the higher population to study this on. I always joke is they get to eat more croissants and pasta than we do. But but yes, their population has such a higher prevalence that it's something that they're easily studied and they have large cohorts to study. And so, we mimicked that study. So the Europeans, used their population database and showed how high this test was. And we did that here in Utah about almost 10 years ago now, and looked at our percent of pediatric populations that had presented with these same tests, the TTG, the DGP, and then we looked at all the ones that were diagnosed with celiac, and we came up with the same numbers. I mean, our numbers actually even seem more reassuring, where if you have 5 to 6 times the upper limit of normal on your TTG, it's almost a 95 and above percent specificity that you will have celiac disease. And so we really put that out there that this isn't just in Europe, this can be here in North America too.
And there are several centers, as you have alluded to, that have moved the standard that direction.
So it's starting to go that way. And this feels like, that Titanic ship that we really tried to get the wheel to turn early, but it's taken, about 4 miles more to get that ship to turn. So our evidence was actually also looked at in Toronto. There's work by Justine Turner up in Canada that did the same thing, where they kind of showed the accuracy and the specificity of these TTG tests being so good that you could forego biopsy. And so now other groups are coming along. Just last year, Danny Mallon out of Cincinnati Children's showed that in the type 1 diabetes population, if you did the two tests together, the TTG IgA and the EMA, you're going to have a confirmation of celiac disease without biopsies when both of those tests are high. And so we've really been the progressive part here in Utah to say that, we could save money, we could save time to diagnosis because you're not waiting 3, 4, 5 weeks to get that scope when we're backed up at the end of the year to confirm this. And so there's a lot of positive reasons to forego endoscopy, I think, beyond just the risk of the procedure, but an earlier change to your body and earlier recovery.
Now, here's something to emphasize, I think, probably for the seventh time by my tally. Should somebody get the test done if they're in the middle of a gluten-free trial?
We will say this over and over and over, but no, even gluten light to me is a little risky. You should be eating somewhere between, and they don't know this specifically, but probably about 10 grams of gluten a day up to about, 30, 40 grams. And that really only needs to be 2 pieces of bread or a handful of crackers. I always tell parents 2 packets of goldfish. And so you have to have gluten in your system to respond in the blood work. And the moment you take that out, you're going to have an inaccurate testing scenario. And so I would just never risk that. Yes, you might be on that pathway to healing, but you're never going to have that 99.5% chance of knowing if you have celiac disease.
And again, I realize I'm asking something for the, I think, seventh time. It's probably not a great idea for me to get TTG test back and say, well, just go off gluten and we're happily ever after. I should still probably involve somebody like you in the thought process.
Correct. And, some people want it to be that where they take out gluten and they notice improvement in their child and then they say, okay, I'll put it back in. But I often laugh at that. I'm like, why would you do that? That seems like a torture scenario, and I laugh that even our cow milk protein allergy guidelines say in order to prove that you should take out cow milk protein or go to a hydrolyzed formula for infants. And then if they improve, you're supposed to put it back in and see if they get miserable again. And I say, there's no way I would do that as a parent. So I caution taking gluten out early because then the ship has sailed for a lot of people, right? And some people would say they're okay with it, but meaning, and by people, I say parents, but you got to factor your kid in on this too. And if it's only my mom thought this was good, what are they going to do in their teenage years or their older years? You don't want to muddy the waters for their whole life. You kind of want to figure it out to be, I think, the most sensible about an approach to a disease. So please leave the gluten in, even doing the serologic testing. But of course, if the family wants biopsies, you're going to have to leave gluten in their diet until those biopsies are done. I would not even say a gluten light diet, even if they have that high serology value.
And how long a period does someone need to be on a so-called normal gluten-containing diet before we can trust the results again?
Yeah, if your families have done their internet research and they come to you and say, I've taken this out for 4 to 6 weeks already before I made this appointment, you're going to have to add it back in probably for that same amount of time, 4 to 6 weeks, and plus probably a 2 to 4 week experience. I tell families 8 to 10 weeks, before we're going to either rebiopsy or retest their blood work.
And we'll talk much more about taking gluten out next week in the treatment of celiac disease. So we'll defer that till then. But it's difficult, difficult
Yeah.
and more complicated than most people think.
It is more complicated. This is the part I'll be a little more optimistic on that, we live now in a world where gluten-free products have really developed and become much more available. They're getting cheaper, I think, by the year. They were seen as sort of a niche product back, 15 years ago and harder for people to find something gluten-free. So that's become more available. With that is the risk we're talking about, though. It's available. The internet is your friend in terms of gluten-free recipes and ideas on where to buy gluten-free products. So the more widely available that is in the public, just as sort of this health idea that gluten-free is healthier, of course, makes the chance that someone will do this on their own a little higher as well.
So reinforcing a couple of things that I've learned today. Number one is make sure that somebody is on gluten when you do the blood work, and that knowing whether someone has IgA is vital in knowing how to interpret the results of tissue transglutaminase. And then if the levels are very high, then collaborating with someone like you is likely to be helpful in terms of whether somebody has a diagnosis or not.
Right. And let me just repeat some of those numbers too. So a TTG IgA has a sensitivity and specificity in those higher ranges above 90%. So 90 to 95% for both sensitivity, positive predictive value, and specificity. So it is the best test. It's not the only test. And if you have a patient in that lower range, so anything above normal or considered abnormal, to probably about a 7 to 8 fold times upper limit of normal, they are still a crowd that could have negative biopsies. So we do recommend that crowd especially come to a gastroenterologist for further diagnostic considerations. That is more of the weeds though too, where someone with 5 times the upper limit of normal in their blood work could, we think, this has not been studied to its full effect, might have early signs of disease, right? Because again, this is a systemic disease before it's a gut disease. The gut is the last to be kind of damaged here. And so there is some thought that we're finding patients earlier because of the cheap and widely available aspect of the test. And so it could be sort of a latent period when you have lower levels of the serology and you might have a risk of a negative biopsy or a normal gut, but you want to monitor that closely. You want to probably repeat testing on a twice yearly basis.
What about people who have done you and me the favor of skipping ahead and getting some testing done beforehand? Maybe testing that's not standard IgG testing, for instance. What do you do with that information?
That is a great question. Same thing about the internet being our friend in some ways, but also making the sky a little cloudy. So you can now get on an internet or through a naturopath person, you can find an IgG panel, and they will test for about every, environmental thing we come in contact with through these IgG panels. And again, IgG just means that your body has seen something, that your body has come in contact with that. It does not mean that it's fighting it off. And I think we intuitively know that as pediatricians, but we need to be really clear about explaining that to our families who see these tests as sort of like the diagnostic version of what we do. And so there are a lot of tests that also with the 23andMe factor or some other genetic saliva tests that come back and say you have a chance of celiac disease. They are not diagnostic. You should not change your diet, in my opinion, based on the fact that some wheat IgG level is high. Well, how much did you gorge Lucky Charms or something else the day before? Although Lucky Charms are gluten-free, but they're not. So yeah, so I think, you just need to tell your families, these are not diagnostic. Let me send you to the physician that can help you with this, or be confident in how you can order the celiac test as well to kind of gauge what the family thinks.
And it may be helpful to look at the results and say, oh, maybe this isn't as helpful as it appeared.
Right. And it's hard because I mean this family has already spent money doing these. It's not
Right.
like you recommended it. And so I think that's a hard thing for a family to hear. Well, they thought they were helping you out or doing a favor to
Right.
their
Right.
child when really it's not that way.
So what's on the horizon for diagnosis? Any emerging tools we should be aware of?
I think it's still emerging that we're going to get there with full North American guidelines for our pediatric group to say you can forego a biopsy with a high enough TTG IgA value. There are a couple caveats to this. There are also some stylistic factors, meaning my style is if you have one very high test, there's still a risk of a false positive. So confirming with a second test is often the way to go, because now you have two things that will tell you that your likelihood is above that 95% or higher threshold. So we have not come up with national guidelines on the pediatric GI side for those yet. I think they are coming. We've had some experts in the field now recommend that our labs are good enough and this test is good enough to forego biopsies. The other things, poop markers is always something I see come up. Everybody wants, their chance to have celiac disease come out through a poop test. There's nothing there yet, and stay tuned for that. But as far as I see on the horizon, we're going to change these guidelines hopefully in the next 5 years or so to forego biopsy if that's what the parents and patients want.
And keeping in mind, too, as we were talking about offline before today's episode, that there are some non-standard tests you can order online that you can send your poop from C to shining C, and those are not as helpful as the advertisements would claim.
Yeah, I'll sound like a broken record probably by the end of this, but our poop really is the black hole of medicine, I say, or the microbiome. And we have some really interesting studies going on, but nothing has been confirmed. And so sending your poop to a repository, number one, I want to know what they do with that and what happens if that poop gets the freezers break down. But yes, we are not there in terms of how to interpret that.
And there should be an up code for how much postage you pay for that.
That's right.
All right.
Make sure it's on dry ice.
At least. Dr. Ermarth, thank you so much for all of your help this week. I think, interestingly, well, it seems like there's potential to muddy the water. I think this is much, much clearer than I have tried to do in the past, and I appreciate that very much. For those of you who have questions, and I know you do, send your questions to questions@vcurb.com, and we'll address those in a couple of weeks. Dr. Anna Ermarth, thanks for your time.
See you next week.
Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Phil Wirkus, who also composed the theme music. See you next time.